Let us continue our discussion on pelvis with part 2. Here now we have the contracted pelvis. So what is the criteria for diagnosis of contracted pelvis? If the inlet is in the inlet also, especially the obstetric conjugate, if it is less than 10 centimeters, and in the case of mid pelvis, if the interischial diameter is less than 8 centimeters, or in the case of outlet, that is a bituberous diameter, that is between ischial tuberosity, if it is less than or equal to 8 centimeters. Okay, so if any of these essential diameters of pelvis is shortened by, so if any of them are shortened by 0.5 centimeters, then you will say it is a contracted pelvis. Okay, so pelvis is said to be contracted if it matches any of the above mentioned criteria. So it can be diagnosed by clinical pelvimetry. So what is clinical pelvimetry? As we discussed, we will put the fingers in the case of ischial spine, we will put the 4 knuckles in the case of ischial tuberosity. This is all the clinical pelvimetry. Okay, so what is the mode of delivery? Always remember the mode of delivery in the case of contracted pelvis is always the cesarean section. So there is no role for trial of labor. We will not do the trial of labor because we already know the pelvis is contracted. So contracted pelvis is indicated for always recurrent cesarean section. So now let us see what are the different varieties of contracted pelvis. In the first one you have the Naegele's pelvis. So Naegele's pelvis is where only one ella is present, that is another ella is absent. So that is called as Naegele's pelvis. And you have another pelvis, that is a Robert's pelvis. So Robert's pelvis is both the ella are absent. So management in the both cases is do the cesarean section, of course, because the ella are absent, so the pelvis can't support the baby's head, just do cesarean section. Now let us discuss the normal varieties of pelvis. Normal varieties based on the shape of inlet. The first one is gynecoid. According to name, you can say it is present in female. It is 50% most common, that is female pelvis. Next, coming to second type, that is android. In the name itself you can see it is like male pelvis, only 20%. Okay, next coming to third type, that is anthropoid pelvis. It is 25%. I will also discuss the shapes of them. So next coming to last pelvis, that is a platypeloid pelvis. This is only 5%. It is like flat bowl shape, or you can say it as flat gynecoid pelvis. If gynecoid pelvis only will become flat, that is how the platypeloid will look. So let us discuss the shape of gynecoid pelvis. It will be transverse oval like this. Okay, and here the transverse diameter, you can see the transverse diameter is greater than anterior posterior diameter. And here if you see the side walls, they are parallel with each other and they are broad, and the subpubic angle will be obtuse in the female. Okay, especially in gynecoid. Next coming to android. Android, it will be like a heart shaped. Okay, and here the transverse diameter, you can see it is greater than anterior posterior diameter, and here the ischial spines will be prominent because it's a male type of. Okay, and here the side walls, you will see they are like convergent, they are not parallel. And next the subpubic angle will be acute. Here it is obtuse because it's female, here it is male, so it will be acute. Next coming to anthropoid. It will look like this. The pelvis, if you see here, the anterior posterior diameter is very higher when compared with transverse diameter, and if you see the sides, they are parallel and very narrow. Now coming to platypeloid. Platypeloid will be something like this. This platypeloid is a flat bowl like. Here the transverse diameter is very much higher when compared with anterior posterior diameter, and if you see the side walls, they are divergent. So now let us discuss about Cephalopelvic Disproportion, that is CPD in short. So CPD, here is the pelvic is normal, here the pelvis is normal, even the baby is normal, but the problem is pelvis is small for the baby. Okay, so in this case the trial of labor is done. You should do the trial of labor here. Okay, and clinical assessment is not used. The best method to diagnose the CPD is trial of labor greater than MRI greater than clinical pelvimetry. So this order we need to remember. Next, coming to CPD can occur at the level of, either it can occur at the level of inlet, which is diagnosed by two methods. Either it can occur at mid pelvis or in the outlet, anywhere it can occur. So first, abdominal method. Next, let us see the methods. The first method which you use is abdominal method. Okay, and the next method you will use is abdominal vaginal method, or also called as Muller-Rocker method or bimanual method. Actually, what we do in this abdominal method is we put our right hand on the near the pubic symphysis, and with the left hand we'll try to push the head of the baby downward. Okay, and the abdominal vaginal method, what we do is we bimanually we take the both hands and we'll try to pull the head downwards. For example, you put one of your hand to pull the head from inside vaginally, and another hand you will put upside and push the head of the baby. So let us see the trial of labor. The trial of labor is done only if there is mild CPD. So if it is only mild CPD, then you can do the trial at the level of inlet. Okay, it is not done in the case of severe CPD, and it is also not done in the case of previous section cesarean section patient if there is mild CPD. Remember, even though the patient have mild CPD, once if she have cesarean section previously, then now also we need to do cesarean section. Remember that. So trial of labor is not done in the case of trial of scar. Trial of scar means already cesarean section is done. So trial of vaginal delivery in previous cesarean section patient is contraindicated. Now let us see the management of CPD. So what is the management? So the first thing is you will do the trial of labor. Okay, so if the trial is successful, then you will deliver vaginally itself. But if it is unsuccessful, then CPD at the level of mid pelvis or outlet, right? So you will do the C-section. So go for direct cesarean section if severe CPD or previous history of cesarean section, and there is no role of any instrumental delivery here. So what is the CPD indicators during labor? Let us see indicators for CPD. That is moulding plus slow progression of labor. Already the labor is slow and there is moulding. In that case we do CPD and capet. Whenever there is capet, succedaneum, and slow progress of labor. So by this we completed the pelvis. Next we'll start with the fetus in another video.